So this was our direct budget, and now if we could ask Dr. Charlie and Dr. Matani to come up, and we are going to answer any questions you have at all about status epilepticus and adults and children.
While our panel are settling here, just want to emphasize on a few things that Dr. Balsamis mentioned, that the most common cause of treatment failure in the status epilepticus is inadequate dosing of benzodiazepines. That's the most common cause. So I want you to, as Dr. Schechter said, delete that 2 milligram standard dose from your mind. Replace it with probably 8, or if you don't feel comfortable, 4 plus 4. Do you agree?
Absolutely.
And you can give 4 milligram, and then in a few minutes, 4 milligram. You have to be very, very aggressive with status epilepticus. As time passes, the risk of treatment failure increases significantly. So you have to treat hard, do your first line, second line, and then if that fails, you go to third line. The other issue that I want to mention, give me 1 second, we'll come back to the question. So I want to bring these issues up, and then you can have, if you have any questions, you can ask the panel in this regard. The other issue is the issue of intubation. Of course, nobody can tell you when to intubate and when not to intubate. It's a clinical judgment, something that you have to determine at the bedside. But when it comes to status epilepticus, it's probably worth thinking about holding on to intubation as much as you can. There are actually good studies that show with adequate suctioning, with a non-rebreathing mask, maybe nasal trumpet and oral airway, you can really manage the airway. Patients can protect the airway. The 4 milligram, 8 milligram, or even 20 milligram of ativan is not going to cause respiratory arrest. Actually, there was a really good study done in 1995, I believe, that they randomized. This was probably when IRBs were easier to get approval from. They randomized the status patients to placebo versus benzodiazepine. And guess which group had more respiratory failure? The placebo side. So their conclusion was that it's really the status epilepticus that causes the respiratory depression and respiratory failure, not the benzodiazepine. So you have, if you treat the status aggressively, you're most likely going to reduce the risk of respiratory failure. The other issue with the intubation is if you intubate the patients too quickly, then you're going to lose the ability to see whether the patient is seizing or not. Right now you have a patient that is seizing most likely, but you're not seeing it. If you work in an institution that they can bring start the EEG monitoring quickly in the ED, that's okay. But if you don't have that ability, probably you want to hold off and allow the first and second line agents to work. And then if you determine, as the guidelines is at 20 minutes time, if the patient is still seizing, then you don't have any option. You have to move to the third line agent, and third line agent means has to be done with intubation. Okay, so if you have any questions from the panel, please speak loudly, and if not, I can repeat the question. Ronnie.
It may not be the right requirement for this, but what I understand it's been difficult to get benzos from the nursing staff lately because there's like a triple lock system now to get benzos specifically out of the fixes, and that it takes much longer than necessary because of the triple lock feature that it takes 2 nurses with 2 different keys to get into benzos. And so we're having a long delay in being able to get benzos into the patient because it takes so long to get it out.
Is this which hospital?
Kings County.
Kings County, okay. So thank you, and I will work with the nurses on that and what we need to do to fix that. Because we need to be able to make these medications rapidly. Thank you.
Along the same
give 8 milligrams of Ativan before, or 12 milligrams in like my alcohol withdrawal seizures, and the Epilepticus does this weird thing where if you order more than 4 milligrams at a time, it changes the concentration or the vial size such that you can't pull it out of the Epilepticus. So the only way of being able to give more than 4 at a time is to order 4 and 4 and 4 and 4 multiple times. Kings County as well.
Thank you. These are important practical things that
We need to know this.
good to
Thank
know.
you.
Yeah.
No?
Yes.
Just a couple of things on the initial issue with the Ativan and nursing staff not being able to pull out adequate amounts in the emergency department. The same problem persists on the medicine floor also with nursing, so just wanted to bring that up. And then in addition, just to clarify, starting the third line agent mission, not giving input to the brain or how much you're administering of the second line agent. If you decide the patient's going to fail the second agent, you just start the third agent on top of the second agent without any adjustments to the second
Yes.
agent.
So you want to make sure the second agent is in. You want,
Okay.
right, so if it's, phenytoin, you want to get it in, and then,
And then you give it a little bit of time for a second agent to work before you move to
and
second, third.
it takes, how many minutes is it, 4 minutes?
I was going to say 5.
It takes around 4 or 5 minutes to get to the brain. So you need to allow that time after you stop, 4 or 5 minutes. By that point, it should be across the blood-brain barrier. And then that point, if it's not working, it's not working.
For Kepler,
I actually don't know the kinetics offhand. I assume it's similar because they're pretty bioavailable, and they travel in the bloodstream to the brain. They cross the blood-brain barrier. The benzos are slightly faster, 1 to 2 minutes, and the others I think were 4. But it was not a head-to-head with levetiracetam. Do you know that?
In the ESET trial, that was a study that was basically a consensus between neurologists and emergency physicians. They agreed on allowing the medication to go in for 10 minutes and then waiting 10 minutes for it to work. So 10 minutes pretty much allows for either of 3 medications to get to the brain and give it some time to work. So that kind of is consistent with the guidelines of 20 minutes to see if your second line agent is failed or not.
so should we only, if we decide to use phenytoin, should we only use phosphenytoin then?
Yes.
Okay.
In fact, it's
Don't use
available. Right. It's the side effect profile is so much better with phosphenytoin. I don't even know if we have phenytoin anymore.
Yeah. And you can get phosphenytoin in 3 times as fast. So you start, it just starts working a lot more quickly.
Phenytoin takes like an hour to get by an IV, right?
That's exactly it. You can get phosphenytoin in at 150 mg per minute, while phenytoin has to be 50 mg per minute.
Right.
So you get it in a lot more.
It's 3 minutes versus 10 minutes. You can do it up 10 minutes if you're at the bedside watching the patient. But for most dosage, I mean, again, it's depending on the
By the way,
things. But phosphenytoin, you can do so much faster, and it's overall is less cardiodepressing. In fact, less hypotension. It's a much safer agent to use. So we actually don't use phenytoin unless for some reason there's an emergency.
By the way, the panel is not just for status epilepticus. If you have a stroke or any critical neuro question, you can ask those questions as well. Back to those.
Just a question about the QI study. Were the patients identified all convulsive status?
Yes. So he took the diagnosis that went through the chart and made sure they were status before they made the cut to be included.
They were all convulsive though?
Yes.
Okay. I guess then my follow-up question is the patients I have a hard time necessarily following the protocol where considering non-convulsive status. And then the question is, should we give this big bolus of 4 milligrams of Ativan when we're already possibly comatose patient and we don't know if this is status? So that's often the conversation I have with a neuro-resident. Give an initial kind of smaller dose and we're going from there. So I just wonder what your thoughts on that is where it's not a clear-cut convulsive status epileptic.
I'm pretty sure the card says convulsive status protocol.
It is.
Okay,
When it's non-convulsive, It's absolutely when you're having the neuro residents involved and the discussion you're having is appropriate.
Okay.
And dumping a big bowl as a lorazepam on the, probably not appropriate because you don't know what you're dumping it on.
I would like to point out that non-convulsive status comes in two flavors. One is sort of a complex partial seizure, which is what we're talking about, which is an urgency but not an emergency. You want to move, but not at the same rate of speed. However, there's something called subtle or burned out status. So what starts out as convulsive status, if it goes on long enough and may happen in the field, can end up without the motor manifestations and is equally lethal. And in fact, you've already now gone out of a period of time, so you need to use the protocol for that. So that's that. So non-convulsive status, you have to be a little bit careful about what you're actually talking about. So for complex partial non-convulsive status, then yes, you can go a little bit more slowly, but for burnt out status, you want to move, and you're late.
So you have a question there, which is were they in convulsive status
To begin.
or when first witnessed, in the ambulance, at home, whatever. And if they were and they're not coming back, then you're going to treat that like convulsive status.
I have a slightly different take, even if I actually, at the end of the day, agreed with the protocol because of all the very good reasons that were pointed out here. But just for simplicity, I like to actually treat all status epilepticus the same, whether it's complex partial or a burned out non-convulsive status epilepticus, just for the sake of having a protocol. I think we should be clear to indeed those 4 milligrams and that escalation in that order. But basically, I was more inclined to say 2 milligrams at a time, because if you are at the bedside and you can get faster 2 milligrams than 4 or 6 out of the fixes, actually you're gonna treat faster your patients with a lower dose. But at the end of the day, I was also pragmatic here, and I felt like because we don't have neurology residents staying at the bedside or even the ER resident staying in the room, evaluating the response after those 2 first milligrams, I think it's perfectly fine to go straight to 4 milligrams. But now we have to resolve the issue of the Pyxis release of 4 milligrams. The other nuance that were just made about, like, well, if it's convulsive status, non-convulsive status epilepticus, maybe we don't want to give too much benzodiazepine because now you have already a stuporous patient, now you're going to completely lose the airway. Well, remember the very good point that he made about the fact that actually most likely it is the seizures that are maybe responsible for the lower level of consciousness, and your added benzodiazepine, if anything, will relieve that and therefore ameliorate the consciousness. So you should never feel bad about, oh my gosh, I jumped to 4 milligrams of lorazepam. Hopefully you will at least only 2, but if here we want to adhere to that protocol of 4, just give them 4, and hopefully they will actually wake up. In my experience, actually, non-convulsive status epilepticus patients that are stuporous will actually sometimes wake up thanks to your benzodiazepine, so don't worry about intubating them. I also felt a little bit differently. Yeah, I think we should remove the phenitoin. We should do only phosphenitoin because, as we just pointed out, it's faster. One contentious point though that was made about, like, no, the phosphenitoin is not having less side effects than phenitoin if you infuse it at the correct rate. So the degree of arrhythmias and hypotension that occur if you infuse it at 50 milligrams per minute, and you compare it to phosphenitoin at 150, which is 3 times faster, will have the same side effects, but just for the sake of simplicity, and because we want to deliver it faster, you're better off only using phosphenitoin, and therefore you deliver it faster. But if you deliver too fast phosphenitoin, you're going to have the same side effects as on phenitoin, which are arrhythmias and hypotension. Which goes along with, I wanted to answer the question earlier on.
But you don't have a pH of 9.
Yes, no, there's many reasons also for preferring phosphenitoin over phenitoin, so just for simplicity we should use that. Your question earlier, I think one said, could we use the side effect or the profile of our patient to choose also an anti-epileptic between phosphenitoin, valproic acid, and levetiracetam. So you said indeed the efficacy is the same, therefore maybe the side effects should be listed. So I wish our protocol was the same. If psychiatry pass medical history, don't do phenitoin. As we pointed out in our second, don't do levetiracetam, sorry. If we have liver failure, it should say, indeed, do not use valproic acid. So you choose your agent basically based on the contraindications. One little hint is that valproic acid is superior to phosphanidone in non-convulsive status epilepticus. So you could even make a stronger case that actually maybe just to be even more simple, we should only use valproic acid. But I like this protocol that gives you the choice of phosphanidone and you can do valproic or levetiracetam. Base your choice on the side effects based on their past medical history. And same thing for the other question that you answered really well about the midazolam versus lorazepam. Lorazepam is superior, and lorazepam and diazepam have been used by paramedics. But more recently, because of the issue of putting a peripheral IV at the scene, the Rampart trial addressed the issue that midazolam was superior just because you shoot it in the muscle. You don't waste your time getting a peripheral IV when you have a paramedic at the scene. But basically, lorazepam should remain in your mind because you're in the ER, you're not at the scene, as the first line therapy. And the midazolam, when we're doing a drip, as she pointed out really well, you are in a completely different mindset. So even if you did not respond to the lorazepam, the very large doses of coma-inducing midazolam drip that we're going to use is it's completely different. So I would still use midazolam even if the patient failed the lorazepam.
Thank you. There's one question. Before we go to the next question, I want to add about the non-convulsive status. That we really, I believe it's safe to say that we don't really know how to treat non-convulsive status because there hasn't been good evidence. Most of the studies that address non-convulsive seizure treatment are on ICU patients. And you have good studies that show actually more than half of the patients with non-convulsive status epilepticus are missed in the ER and they're diagnosed more than 24 hours after the presentation. So a non-convulsive status that has been cooking for 24 hours is a completely different animal from what we might see in the ED area. So there hasn't been really good ED study to show how to treat non-convulsive status epilepticus. We don't have a good evidence in that regard. Dr. Smith.
Pepper. I'm not sure if you guys spoke about pepper, but most of us are loading pepper.
That's fine.
Yeah, so 50 milligrams
Is that
per kilo.
What's the difference between pepper and froth?
I'm sorry, what's the difference between what? Pepper and
Protocol? You can choose between
it's in the
pepper and
protocol.
froth.
So
So what would be the difference? What,
at
is
this,
there one where you would use it more than the other?
but at this point, there's sort of equipoise as to which of these agents can stop status. So the levetiracetam, the phenytoin, the valproic. Traditionally, we used phenytoin, but we're now switching more to using levetiracetam. This is the point that I made earlier, and it's fine. They're all equally efficacious anyway, depending on the clinical situation, you prefer one or the other. Whichever one you're comfortable with, as long as you're dosing it appropriately, is important. So you need to make sure that you get, it's on the purple copy, the appropriate dose of each of the medications.
I'm glad Michael just said that because that's one of the things that I see in the QI project, that at least 50%, well, many of the patients were treated with lorazepam correctly, but 50% of them didn't get the correct dose. So I've been hearing a lot of 4 milligram, but I think this is one area in which adults is very much like peds. It's 0.1 mg per kg, and we have to remember that. If you just give the 4 milligrams and then go to your phosphanidone, you haven't completed the first stage. And the second point I wanted to make, and I know Dr. Balsamas just covered this beautifully, as we're talking about phosphanidone, valproic acid, levetiracetam, it's really important that one of those three gets in. What we see at this ED more than anything, and I haven't done this QI project, but just the cases that have been problematic, is we've gone from step 1 to step 3. We've gone from 2 or 4 milligrams of Ativan, having completed it, and then gone to propofol. So I think getting that phosphanidone, levetiracetam, valproic acid in is so essential.
I want to point out, this is actually from our Hopkins data, that one of the concerns was in our DDs here, we are intubating more than other DDs around the country. And that happens if you go from 1 to 3. So that step 2 is really important. And in 55% of the time. So you can avoid intubation most of the time with that.
Thank you, Bob.
In going from that step 2 to that step 3, after you've loaded an anti-epileptic, how much time are you giving the patient sequential response before you move on to step 3?
10 minutes.
10 minutes max.
Roughly 10 minutes. I mean, there's really not much evidence-based, but most people say allow 10 minutes for infusion, allow 10 minutes for it to work. At 20 minutes, if you haven't seen any results, your second line is failed to move to the third line. Yes, Mon.
If, say, you for whatever reason have to jump to intubation, which after it, between your airway, what have you, should you then backtrack and do the orbital, or should you just stick with?
It's not backtracking.
You're not, well,
It's actually not
skipping it.
backtracking. I guess for you guys maybe it is, but for the patient it's not. Because if you just go from Ativan to step 3, once you've resolved their status, and now you don't have them anymore, but they're in the ICU, and they're backing off on the propofol, what maintenance AED are they on? So it's not backtracking, it's really an essential part. Very often,
I meant more, you're giving the pepper up.
Oh, sorry.
Maybe a 60-minute range where you're normally trying to get orbital or go into intubation.
oh,
That's
so that step is interesting. That's really sort of traditional, and I think,
Sorry, can you repeat the question?
I think she's asking if you've given your phosphonatoin levetiracetam valproic acid, can you go to propofol midazolam, or should you give that phenobarb, which yes is in the protocol. So it's not incorrect to do it. Most of us are skipping that now. There's been an evolution in the protocol and the treatment of status over the last 10, 15 years, and I have a feeling, so the newest protocol, I think at MGH doesn't have that there anymore. And we tend to follow that. So I'm pretty sure it's going to be dropping out soon. So not doing that is okay. That's sort of like step 2B. You could go from 2A to 3.
And I thought you asked the other question, and I think that's also a good question, that what if you give benzo and then you have to intubate and you put the patient on propofol? Do you still give a second line agent or not? Yes. Right? The answer is yes, because what third line agent do is they cause burst suppression, which is just like a asystole of the brain, but you still have to give something to stop the seizure, like I said.
It's going to go over venous, but stroke, epilepticus, whatever, you have some patient that is critical enough you have to take. Which of those agents are best? Which has the best fusion versus whatever? Versus we go to an ICU is very extended. What medication is best to keep them on maintenance sedation?
So we're talking about step 3, the patient is intubated.
Just any reason, neurologic reason the patient is intubated.
Oh.
Massive hemorrhage or something. So
Yeah.
what is best for prolonging sedation?
And you want to compare midazolam to propofol to pentobarb?
Yeah, four choices.
Yeah. Well, number one, you should ask yourself about efficacy, and as same answer as for the step 2, basically, there is no proven superiority of one of those 3 agents to control seizures. And I'm saying control seizures, not even induce burst suppression, which, by the way, we're saying we should shoot for that. That's just for use for simplicity, but actually, once you get to the ICU, there's a lot of arguments to be made against shooting for a burst suppression pattern. But anyway, those 3 agents are equally effective, and therefore you should choose the agent based on the side effect profile, as we said for step 2. Same for step 3. That is why somewhere it says do not use propofol if you have a hypotension already to begin with, and therefore midazolam is usually the preferred agent. Pentobarb is unfortunately also dropping the blood pressure and the respiratory. So the way I hope it translates in this, but it's exactly listed in the protocol I've written in Tarascon Neurology, those pocket books, is if you have hypotension, use midazolam. If you have a chronic respiratory failure patient, somebody that was already intubated in a NICU 1 month ago or whatever, don't use benzos because you get a committing to long-term mechanical ventilation. Therefore, you can prefer propofol. And if you cannot use neither propofol nor midazolam, that's when we report, unfortunately, So use your side effects profile to choose because the efficacy is the same. And the second part of your question is also not only about efficacy and avoiding side effects, is there data on cerebral blood flow and ICP and blah blah blah. Well, it depends what is your brain disease, but if you have ischemia, it sounds like actually propofol is preferred. If you have midazolam on board, it does not lower the ICP as great as propofol. Propofol has maybe some more neuroprotective effects as well as reducing the metabolic rate of the brain much more, therefore also reducing ICP. So if you have a traumatic brain injury and in which I want to control seizures, I'm going to try to use actually propofol to kill two birds with one stone. Kill the seizures and abate the ICP crisis and actually make three birds. The lowering of the metabolic rate will reduce the neurons will be hibernating, therefore even if they are not happy, maybe the patient will wake up in a month better off. And in terms of cerebral blood flow, there's no difference except that of course because of the drop in the map, because of your propofol or your pentobar, midazolam might be a little bit better. So that's how I would choose it. But basically the answer is there's no big difference. You can use either three. Thank you.
Just on one point that you said just now, when I tried to get propofol in like a closed head traumatic injury type of scenario, trauma has been very, very against that because it's dropped the ICP. So trauma's told me multiple times that it's contraindicated to get propofol in closed head injury.
No, propofol is a great agent because it lowers the metabolic rate of the brain. So even if the neurons are not receiving enough oxygen, at least they will be sleeping basically for a week or whenever how long you continue your propofol. It lowers the ICP, so it is an excellent drug of choice for traumatic brain injury. But if you're lowering the ICP but even more dropping the MAP, then your CPP will be compromised because you drop the MAP even more than your ICP. So then the perfusion of the brain will be compromised, but don't worry, you can fight that with norepinephrine. So you can still use propofol and start them on norepinephrine. Thank you. That's your question.
So I had a question about patients who initially appear to be controlled when they come in with status, but then start seizing again a little bit later. I recently had a patient that got benzodiazepines in the field, came in, got loaded with 1,500 at Keppra, and when I went to see her, she was somnolent but arousable, so I didn't think she was in a non-convulsive status. She was answering questions, but then immediately started to seize again. In that situation, do you immediately go on to step 3? Do you go back and redose Keppra again? I'm just curious as to a patient that looks like they're out of status and then goes back in.
Everybody got the question? So the question is if you have a status patient, you give the first and second line agents, there is an improvement in their mental status, but then they start seizing again. What do you do next?
Well, you didn't give the first line agent, right? It was given in the field.
Sure.
I would give the first line agent again. I would go back to giving the Ativan 0.1 mg per kg. And then if you said got 1,500 of Keppra?
Yeah, got loaded by us.
Well, so what's the correct load? So go back and calculate what's the 30 mg per kg, and I would supplement that extra bit of Keppra.
But I mean, the loading dose of Keppra is different if you're in status versus just a regular dose, right? Like, the 50 mg per kg is if you're in status, but as far as
30.
you know, that's not the same loading dose where if you just have somebody who comes in, has
And you
seizure,
start
check the
Keppra.
baseline, and you want to load
Correct.
the Keppra, it's a different load.
Correct. Right.
So they might have gotten that one, and I might have added on. to get-
I would make up the difference. I would add that back in.
And that's actually exactly what happened, was we gave 4 milligrams of Ativan, and then per neurorex, we would give another 1,500 of Ativan. I just wanted to hear your
And more Ativan. Sorry. 4 milligrams.
Yeah, when the second seizure started, got another 4 of Ativan, and then the neurorex is to give 1,500 mg more Keppra, so it's kind of what you were saying.
No. I say get up to your 0.1 mg per kg. Give all your Ativan. If they stop seizing, no, then you're done. And then you're right. But I didn't get that impression. If she stopped seizing, then fine, then make up the difference with the Keppra. But if she didn't stop seizing, I'd keep giving Ativan up until the correct dose.
But the point they make also is, what is the difference between seizure versus status? And she presented with a seizure, but then went into a second seizure, so then now you're calling it status. So they're now finally implementing the status protocol. But I would say that when the patient had only a seizure and they're only barely awake, assume non-convulsive status epilepticus, therefore you need to already err on the side of treating like status epilepticus. So I know you said the data is not that compelling for non-convulsive status epilepticus being treated in the ER as aggressively in the ICU, but what you have to do is, and how many patients do you need to see again seizing? Oh, now it's status epilepticus. So come on, err on the side of, if you're not perfectly alert, attentive after a seizure, give them 5 minutes, but that post-ictal, oh, don't worry, it's just post-ictal, that is a misconception. Most of your post-ictal patients are actually in non-convulsive status epilepticus. So I would prefer that even before that second seizure, you would have assumed, guess what, I need to complete my lorazepam and I need to give more than just the 1.5 grams of Keppra. You will harm less patients by assuming status epilepticus rather than waiting for that second seizure to confirm that the patient is entering status.
I guess one other thing, depending on the hours, the call for EEG really are far more available than we're utilized. Kings County, I'm impressed that it's being utilized a lot more in EEG. Downstate, I think that there was years ago an impression that we're not available to you. We're absolutely available. 2 o'clock in the morning, Monday, no. But certainly typical business hours as well as Saturday and Sunday. And call the neuroconsult anyway, because depending on what time it is, potentially we can get somebody in to start the EEG.
Yeah. I have sent several emails about availability of EEG, stat EEG during office hours, thanks to Dr. Mortati. So I'm happy to send that email again. You can get actually EEG done quickly in EEG, and you should really be mindful of non-convulsive seizure. A lot of, I think roughly the number, if I'm not wrong, the number is 25%. About 25% of patients who come with the status, convulsive status, they go on having non-convulsive status. And as I said, the data for, we don't have really good data to how to treat non-convulsive status in the ED, but it is safe, as Dr. Kelvin said, to adhere to the same principle of convulsive status, or at least get the neurology involved earlier and work out the treatment plan with them. Get your EEG quickly, you can get it, and I have been impressed, especially at both institutions, how quickly we can get a stat EEG. I will send the email again, but basically you fill out, you fill out the consult sheet. This is at UHB. You fill out the consult sheet and fax it to the EEG suite, and then call them and say you need a stat EEG. They'll come down.
Yeah, make the phone call too.
Yeah.
This is, I guess, just a question of, not maybe back to work with, but I guess sort of question is, what is the neurology resident's ability to really eat? So a lot of times you have a situation where the patient's on EEG monitoring, residents for CT, great, they look at CT, I think that's very well, but if they come to read the EEG, from your perspective, is it something that like it's doable, and if it's so, is it something they can do EEG, is it something else?
I think it varies. I think some of the senior residents have pretty good capability of deciphering status and non-status. However, where you guys are in the ER, both ERs have ports. Kings County. Oh, Kings County, we can't, while it's running at Kings County in the ED, we can't see it. We have to wait for the tech to upload it. At UHB, that's not the case. There's a port down there. So the resident can call epilepsy fellow, who can get online in the hospital or at home and look at it. And that will be the case at Kings County.
When they're looking at the screen and they're seeing the waves, is it something that's reasonable for them to interpret reliably?
I wouldn't count on their read, even though I'm saying that I think some of the senior residents have a pretty good grasp of what's status and what's non-status. But literally, the epilepsy fellow is a phone call away and able to pull it up. We're able to pull it up anywhere.
It streams live at downstate, so they can log in and look at it. Otherwise,
But as an alternative, anyway, always involve the resident. The more they're going to feel uncomfortable reading it, the better they're going to learn from you guys. And number two, I would say they can still take a snapshot and send it to the fellow or to me in order to give you an instant read, because as you're pointing out, we're ordering an EEG, but there's no read until the next morning, which has been an issue in the entire field of epilepsy. So whether you're online or not, you also need, within 15 minutes, you need to hear from an expert telling you, yes, the patient is in status or not. And that is why, because almost nowhere, even at Yale and Columbia and all that, they don't have the 15 minutes that I just recommended for an instant read on every single emergent EEG. That is why in our protocol is saying, you know what, shoot for burst suppression, because that, I mean, a 5-year-old can tell you if you're in a burst suppression pattern or not. So that is why until we have instant reading, we need to rely on that.
That's it. Ahmed, did you have a question?
Yeah, it was a question about using Keppra and the dosing, like 30 minutes per kg.
50 milligrams per kilogram.
I'm sorry, 15 minutes per kg.
No, not 1.5, 50, 50.
In a regular patient who comes in with a seizure and you're just loading them with Keppra, right?
Oh yeah. So if it's only a seizure and not status epilepticus, it would not be unreasonable to give only a gram or 1.5 grams, yes. However, once the patient is not only postictal, you're worried that they are in status epilepticus, and you should always think that it is that instead of postictal, then you should assume that the patient is in status, and therefore you should give more.
My question is, why not just give 50 mg per kg?
To every single seizure? No, that would be
It's
too
sedate
much.
them.
It can also sedate, although less than valproate. And if we really give 50, that's close to 5 grams basically for a 100 kilos person. No, we're going to have a lot of psychotic side effects, so we're not recommending that. However, if you ask me the question, is there a value of giving more benzodiazepine, even in a non-status patient? They just had a seizure. A few of you are asking me, even neurology resident. We enter the room, oh, the nurse just told us he was seizing 5 minutes away. We don't see a seizure anymore. And they're like, oh, now the lorazepam is here. Dr. Capinos, do you still want to give it? And I hear half of my residents saying, no, the seizure abated on its own. We're not going to give benzodiazepine. That is a misconception. Benzodiazepine abort a seizure, but it also prevents a recurrence of a seizure. So if you're convinced that your nurse didn't misconceive the spell and it was truly a convulsion, I tell them give lorazepam in order to prevent a further seizure and the development of even status epilepticus. So yes, you can give lorazepam 2 milligrams to a patient that is not actively convulsing in front of you if you are pretty sure that there was a convulsion recently.
Thank you, Lewis.
Just about the protocol, let me see it in addressing disposition at all. I'm just wondering what you guys' opinion about, obviously the patient gets intubated on the trip and goes to the ICU, but if the status is terminated maybe in step 1 or 2, what do you think the patient should be admitted to?
As far as pediatric patients go, we still want them to be in the ICU.
Yeah, it's easy.
Thank you, Louis. That's all.
I'm actually not totally sure where they go. I usually am involved a little bit later when they're not responding to agent number 3. I see a lot of them wind up in the ICU overnight, get extubated, and sent to the floor the next day. I think that's totally reasonable considering the severity of what they came in.
But the question is mostly about the ones who have status, they don't get intubated and they stop seizing.
If they're intubated, it's easy.
Do they need to be in a monitored setting after post-status for recurrence of status?
I guess the question is, should every status epilepticus patient be seen by the ICU?
If they're not intubated.
If they're not intubated. Because this is a problem we have on the ground floor when we're dealing with.
They should be seen by neuro. I guess they have been seen by
They're
neuro?
all seen by neuro.
They're all seen by neuro.
Well, the problem is, if you send them to the floor, they're going to be, the neuro floor is what, Q4 hours, right?
Yeah, that's not
I
great.
think that's not adequate. And you need your EEG, so err on the side, as you said, put them all in the ICU.
Okay.
Huh?
All right, Any more questions? Thank you very much for